all. Professor Dr. GAURAV BHATT, MD, Homeopathy and PhD. PG Diploma in Emergency Medicine, Medical Service, Certificate in Child Health, Certificate in Child Principal Ahmedabad Homeopathic Medical College, HOD, Department of Physiology. Presentations at various national and international level. Presented many research papers and winner of many awards. His contact details are there. You can see in the his biodata in our Zoom our daily Zoom advertise. So more than 14 years of clinical experience. Today, he is dealing the subject, sciatic. One time, have growing and growing, becoming older and older, that time sciatica. And mainly, ladies are more affected with sciatica. Sometimes it may be severe, and after the COVID period, I have seen that many cases of sciatica after taking the COVID vaccine. They are also saying that diminution and everything is happening, and that is also we have to distinguish between the cases of after the vaccination and the conditions of sciatica. And so I think that I believe that Dr. GAURAV Bhatt will give us a detailed study of it, because he's he's a teacher in physiology. So the most development of the world, he can say now, the modern world and his the scientific development, he can correlate with all the things with our this disease. So you are welcome, doctor. I think that this is the first time, isn't it? You're coming.
Yes. Good evening, sir. I'm speaking on this forum for the first time, and a very hearty good evening to everyone. Thank you, Dr. De Silva, for my introduction, and my heartiest pranam to Dr. Sahani, sir. Thank you, sir. Thank you, Sahani, sir, for inviting me, giving me this opportunity to speak in front of such learned audience. And I can see the efforts of the team of IFPH for organizing these webinars on a regular basis. And all kudos to your team, and especially Sahani, sir, who has taken all these efforts, and he has invited various experts from various corners of India and given them the opportunity to speak. So I thank Sahani, sir, from the bottom of my heart. And I hope that today's topic that yeah, just a second.
Yeah.
Am I audible, sir?
Yeah, I shall make you co-host. Then you can share your screen, sir.
Yes, sir. Please, sir.
Okay. Yeah, I made it. Okay. Now you can do.
Yeah. Okay. I'm just trying, sir.
Just a second.
Is my screen visible, sir?
Yeah. It is visible. It is coming. Yeah. Okay.
Yes. Okay. Yes. So
good evening to everyone present over here. And my sincere thanks again to Dr. Sahani, sir, to giving me this opportunity to speak on the topic of sciatica and its homeopathic management. So what I have tried in this topic, because I have been observing patients of sciatica right from my internship days, to be very frank. I have also worked on the same cases very diligently during my MD days also. And I have pursued studying of sciatica because when I first went through the literature of this topic, my inquisitiveness came from that sciatica, it is a simple pain or a simple radiating pain, as we all know, related to the sciatic nerve. But when I went into the depth of the literature of sciatica, when I read not only the medicine part, not only the clinical part, but when I read the homeopathic part, at the same time, when I read different scales which are nowadays used to measure sciatica or measure the treatment or the outcome of sciatica, I was astonished to see how much work has been done. And at the same time, I knew that there is a lot that we can do and help patients with homeopathy in sciatica. So let us just begin. What I've included is a history part, a little bit of literature part, in which I'll tell you about what sciatica exactly is, what are the exact causes of sciatica. And I've also included the organon part, the materia medica part, a little bit of repertory part, and some of the cases. At the same time, I've also included some scales which I use to what you can say measure the outcome of the treatment in my patients. So let us just start. Let us begin with what history has to say about sciatica. See, sciatica is nothing like it is a what you can say a topic or a condition that has come overnight. It is right from the time of Hippocrates, wherein Hippocrates said that the increased seasonal powers of the sun might dry up the joint fluid. And he was of the opinion that this was the reason which was leading to sciatica. Now, he was the one who gave us a very astute observation of the relationship of sciatica, posture, and claudication. As we all know, that whenever a patient or a person suffers from sciatica, the first thing that goes out of context, or you can say which alters physiologically, is the patient's walking pattern or the posture. So when we say that observation is important when a patient comes to your clinic, a patient of sciatica, when he or she enters your clinic, just by seeing the claudication of the patient or the posture of the patient, many a times we can make out by that observation that he or she might be suffering from sciatica. So it has been said since ages that the posture, the antalgic posture, is most important to observe. Like, apart from Hippocrates, the Romans also continued to confuse sciatica with diverse pathological processes. They were not sure whether to name this condition as sciatica or gout or osseous tuberculosis or simple dislocation of the hip or poliomyelitis. So because they were confused and they did not have a particular what you can say a diagnostic terminology for it, the treatment that did not evolve at that time. The treatment remained a very, what you can say, concentrated only on a particular pattern. So that is why, in spite of having many manifestations, the treatment of sciatica was not to the point it was treated. So our Indian medicine, see, we say that our medicine is one of the oldest streams of medicine. So outside what the Greeks and the Roman believed, ancient Indian medicine underwent a largely independent development. And here the concept of murmurs, the murmur, what we say, they gave importance to this even while studying sciatica. So although clear descriptions of sciatica are very infrequent in the Indian medicine text also, but it is said that the Kakundram murmur, which is located approximately in the lumbosacral area, when it was injured, you expect the loss of sensation and paralysis in one of the lower extremities. This is what our ancient Indian medicine or the ancient Indian medicinal text they have quoted. So this is what is similar to we believe nowadays, because we all know the origin of the sciatic nerve. We all know what is the lumbosacral trunk. We all know what are the nerves that are coming through that specific foramina. So this concept was there. And further on, when it was studied, we got the idea of the modern medicine sciatica. Now, when we say sciatica, as in the last slide, I said that we consider sensation, we consider paralysis, we consider numbness, we consider tingling. But the most annoying thing that a patient suffers from sciatica is the pain of sciatica. Now, when we say pain, research has been done where researchers say that to measure pain from mild to excruciating, you need a unit, and the unit of pain that has been given as DOL, that is DOL. So researchers say that there are 11 possible different DOLs which a human can suffer from. But it is doubtable if many of us can grade the pain very accurately. See, if someone asks me if I'm having headache, if somebody asks me, okay, what dole of pain are you suffering from? So it is totally a subjective feeling. Okay, so it cannot be specifically graded. You cannot specifically grade the amount of dole of pain that you are suffering for. But to categorize this or to simplify this, doctors have classified the pain into basic three categories. That is, first, a pain that you can forget. Okay, chalo, hai, and then you are forgetting. Second, a pain you cannot forget. And the third category is a pain that makes you forget everything else. So this is the most severe category. So upon these three, if you are able to classify the pain of your patient in these three categories, you are able to classify the severity of pain that your patient is suffering from. Now coming to what you can say, the sacral plexus, the anatomical part, let us just clear out fast let us just revise, I would say, what anatomy has to say. In human anatomy, the nerve plexus, which is the sacral plexus, it provides motor and sensory nerves. Now, motor sensations and sensory sensations to the particular areas of posterior part of the thigh, most of the lower leg, the entire foot, and part of pelvis, it is given by the sacral plexus. So it is part of the lumbosacral plexus and emerges from the sacral vertebra, that is S2, S3 and S4. Now what is this sacral plexus? It is formed by the lumbosacral trunk, the anterior division of the first sacral nerve, and the portions of anterior division of the second and the third sacral nerves. Okay, so the nerves forming the sacral plexus, they come together, what we call as they converge together in the lower part of the greater sciatic foramina. And when they come together, they unite and they form a thick flattened band from the anterior and posterior surface. Okay, and this thick band coming together of these nerves forming of the flattened band, this band together is continuous as the sciatic nerve. In the next slide, when I show you the picture, it will be more clear to all of you. You can see in the single picture, I have tried to show whatever I spoke in the last 2 to 3 slides. Okay, you can clearly see the superior gluteal nerve, the inferior gluteal nerve. You can see the posterior cutaneous nerve of the thigh, the pudendal nerve, where they are originating, from where they are coming. And you can also see how the lumbosacral trunk is formed. And when this lumbosacral trunk, it is coming out from the greater sciatic foramina, it is continuous as a band, which we call as the sciatic nerve. Okay, so this is a more clear picture where you can see the relation of the nerve with the muscles, the major muscles which are present in that area. So you can see the gluteus maximus muscle. Now, see, this is not only for the purpose of showing, I'm showing you this slide. When we go to the cause, you will be able to correlate this again, that what role the muscles play in cases of sciatica. What role these muscles play whenever your sciatic nerve is impinged upon or it is being compressed upon. So all this muscle, gluteus maximus, semitendinosus, vastus lateralis, biceps femoris, and sciatic nerve, they are in close proximity. As you can see, this is a picture that I have shown from the dissection point of view. And you can see how thick our sciatic nerve is. So coming to the main part of today's presentation, as we all know that sciatic nerve, it is one of the longest nerve in the body and branches out from the spinal cord in the lower back through both the buttocks and the thighs. The sciatic nerve and its branches are responsible for movement and feeling in the legs and the feet. Okay. Now, when you say sciatica, sciatica in itself is a group or a set of symptoms. It is not a diagnosis in itself. Let us make this very clear at this point only. It is not in itself a what you can say a diagnostic condition. Okay, it is a set of symptoms which may be caused by the general compression or irritation of one of any of the 5 spinal nerve roots which give rise to the sciatic nerve. So what the patients usually complain, it is of pain while walking or standing, but sometimes reverse of this happens. So the patient might also complain of pain while lying down in a normal sleeping or lying position or posture, and the patient has no other option other than to stand or walk. Now, believe me, this is the most troublesome part, because when the patient is having trouble while walking or standing, he or she can sit and have some relief. But what will happen if the patient has pain while lying down or while sitting? He or she has to continuously stand up or lie in some uncomfortable position to get relief from that pain or tingling or numbness. And that becomes very, very difficult for the patient. So that is the case that happens in some of the cases. And the pain is felt in the lower back, buttock, or various parts of the leg and foot. In addition to the pain, which is sometimes severe, as I told you, there will be numbness, muscular weakness, tingling difficulty in moving or controlling the leg. Now, these are the symptoms which will come one by one as the disease progresses. Okay, so if your disease has progressed to the level wherein your patients start complaining of difficulty in moving of the leg or muscular weakness, now that is something that is alarming. Okay, then at that point, you need certain alarming level of treatment, because muscular weakness is there, muscle wasting might start, the patient is not able to move the lower extremity. Either it might be a single lower extremity or both the lower extremities, because sciatica can take place on one side or both the sides. So that is very troublesome. And particularly seasonal variations are also seen, wherein the pain is severe whenever the prolonged exposure to cold weather is seen. Okay. Now, how important it is to have knowledge about sciatica. So I will talk about the prevalence. In recent data, it says that sciatica occurs in about 1 out of 100 people who have low back pain. Now, I might tell you this, that there is one textbook of medicine known as API textbook of medicine. It is a very authentic book, right? Just like our Davidson textbook of medicine and Chamberlain and all. If you read API, if you go to the index and find out the chapter of low back pain, it is one of the finest books wherein low back pain is very well presented. So if you say that if 100 people are, so I just suggest to read that low back pain chapter from API, wherein you will be able to see that out of 100 people, 1 people has sciatica. Okay, so sciatica has been reported to occur in 1 to 10% of the population, and the most common age group is 25 to 45 years. So this age group is the age group which are the most active people, who are working, who are job oriented people. So in this age group, if you are having a condition like sciatica, it is very troublesome. And it is estimated that about 5 to 10% of patients with low back pain have sciatica, whereas lifetime reported prevalence of low back pain ranges from 49 to 70%. So out of this, you can make that if at all in a lifetime, there are 49 to 70% chances that an individual will have low back pain. And similarly, out of this, 5 to 10% will have sciatica. So that comes to a very staggering figure of 1 people out of 100 having low back pain will suffer from sciatica. So this is very important and alarming nowadays. Now coming to the types of sciatica, if you want to classify sciatica, there are mainly 2 types. One, you can classify sciatica depending upon the duration, and one is depending upon the origin of the pain. Okay, so depending upon duration, typically you can classify it into acute sciatica or chronic sciatica, which we call it as short-term or long-term. Now, what do you mean by acute is, it may be foregoing between 4 to 8 weeks and the symptoms can be significantly reduced. But chronic sciatica, it persists for a longer period of time, more than 8 weeks usually, and it always requires physical therapy. Like along with medicines, you will always require exercise, heat fomentation, cold fomentation, and some other techniques. And in very rare cases, you cannot ignore surgical intervention. So this you should definitely correlate, okay, because it is such a case wherein your spine is involved, your spinal nerves are involved, right? So you must be very vigilant enough. We must be very vigilant enough when to advise the patient to go for surgery or not to go for surgery. The second type on which we can classify is depending upon the origin of pain, that is true or pseudo sciatica. Now, true sciatica is caused by the compression of the lumbar spine nerve root, and its main cause is a herniated vertebral disc. This we all know that this is the most common cause which leads to the compression of the lumbar spine nerve root. Pseudo sciatica, pseudo as the name suggests, false sciatica, it is caused due to compression of peripheral regions of spinal nerve. So in true sciatica, it was the direct compression of the lumbar spine nerve root, and here in pseudo sciatica, it is the peripheral region of the spinal nerve. But believe me, it is just the name pseudo, but it is as severe as a true sciatica. So it may be caused by some unhealthy posture or certain sports activities, lack of exercise, and many other activities like sitting or standing in a particular position for long periods, sitting with a wallet in the back pocket. This is a very small thing you might consider, but sitting with the wallet in the back pocket might result into it. I'll further elaborate this thing when we study the further causes. And then sitting on chairs with high seat. Now, why this is important? Because as I suggested, or as I showed in the previous slide, that 25 to 45 years of age group are more prone to these conditions. Now, when you say this age group, most of the people who are working mostly in the IT sector, I have many patients from the IT sector wherein they have their extended work hours of 8 hours or 9 hours, wherein they are hardly able to stand up for 5 or 10 minutes. So in such cases, the chances of patients suffering from sciatica increases drastically. Coming to the causes, the first cause is spinal disc herniation, as I told you. Now, mostly it is because of the compression of L4 or L5 sacral nerves, S1, S2, S3, or by compression of directly of the sciatic nerve itself. So spinal disc herniation, a very common cause. Now, what happens is a herniated disc. Now, this is important to know because we all know what is spinal disc herniation. But what happens because of this? It is sometimes referred to as slip disc, ruptured disc, or bulging or protruding disc. Now, when the bulging disc is there, it is also known as a contained disc disorder. Now, why it is known as a contained disc disorder? Because the gel-like center, that is the nucleus pulposus, that material, it remains inside the annulus fibrosus. It does not come out. Okay, this is important, and this will definitely have a impact on the severity of the condition. Okay, so if it is a contained disc disorder, the nucleus pulposus will remain inside, and it will not come outside the annulus fibrosus. But if at all there is a rupture of annulus fibrosus, this nucleus pulposus, this gel-like material, will come outside if there is a rupture of annulus fibrosus. And when it comes outside, it is known as a non-contained disc disorder. Now it is not a contained disorder. Okay. Now, this is more dangerous because what happens is the material which has come out, it contains a acidic chemical irritant known as hyaluronic acid. And this hyaluronic acid, it will start causing nerve inflammation. And this nerve inflammation is a very acute condition, and the pain is of the most severe type. Okay, so in both the cases, whether it is contained or non-contained, nerve compression and irritation, it leads to inflammation and pain, often leading to numbness, tingling, and muscle weakness. So this inflammation and irritation are the causes of the symptoms of sciatica. Next common cause is spinal stenosis. As we all know, stenosis means narrowing. So the narrowing occurs in the lower spine, and the lumbar and the sacral nerve roots may be affected. And the condition typically results from one or more of the following conditions, such as if the facet joints are enlarged, if there is any overgrowth of the soft tissues, and a bulging disc is placing pressure on the nerve roots when they are exiting the spine. Okay. Then in spinal stenosis, if the cause of sciatica is spinal stenosis, then the pain will usually be positional, often brought on by activities such as standing or walking, and relieved by sitting down. So now why I'm telling you this again, I told you that this will come. The importance of posture will come when I talk about causes. So here is the importance. Like when we ask the history of the patient, if the patient says such things or such modalities, then our mind should start thinking about the causes. So if you get this similar aggravations, ameliorations, then you must think about the cause of sciatica as spinal stenosis. Okay. Another is piriformis syndrome. Now, this is what I meant by when you, or particularly males who have the habit of carrying their wallet in the back pocket. And if you have the sitting habit wherein the wallet is compressing on the piriformis muscle, then it will give rise to sciatica. How? I'll tell you. It is named from the piriformis muscle and the pain caused when the muscle irritates the sciatic nerve. Correct? The sciatic nerve also gets irritated as it runs under the piriformis muscle. Now, ideally, the sciatic nerve runs under the piriformis muscle, but in 15% of the population, the sciatic nerve runs through the piriformis muscle. It does not go below or beneath the piriformis muscle. It runs through or in between the piriformis muscle. Okay. So such conditions are known as entrapment neuropathies, because here the nerve is getting entrapped in between the muscle. Okay. So colloquially, it is referred as wallet sciatica, since a wallet carried in the rear hip pocket will compress the muscles of the buttock and sciatic nerve when the bearer or the patient sits on it. Okay. So piriformis syndrome may be a cause of sciatica when the nerve root is normal. See, don't always think that your L4, S5, S1, S2, S3 are compromised. Your nerve root coming out of the greater sciatic foramina is getting compromised. It might be a simple entrapment neuropathy. So herein you need to give treatment accordingly so that the patient gets relief. And this is an acute condition which can be treated faster as compared to some other causes like herniated disc or spinal stenosis. Next is spondylolisthesis. Now, this is a condition which is characterized by when one vertebra, it gets slipped over the adjacent vertebra, like L5 slipping over S1. So S1 is the adjacent vertebra to L5. So this might happen in these cases. Okay. So when a vertebra slips and it is displaced, the spinal node compression might occur and it might often cause sciatic leg pain. Now, spondylolisthesis can be categorized as a developmental disorder because it can happen at birth or develop during childhood, or sometimes it is acquired from spinal degeneration, some trauma, or some physical stress like weightlifting. So you might know weightlifters, they suffer from this condition. Even in cricket, fast bowlers, like you might have heard about bowlers suffering from stress fractures in the back. So why does that happen? Because when they come and bowl, they thump their front foot. For a right hand bowler, the left foot will be the front foot. For a left hand bowler, the right foot will be the front foot. So when the bowler thumps his foot, and this thump occurs with a lot of pressure, and when this occurs time and again for years together or months together, it leads to the rupture in the lower back, and this might lead to the vertebra slipping over one another. So this is because this condition might also happen in what you can say sports person. Trauma, as we all know, like motor vehicle accidents, or if you have a sudden fall, or some sports also like football and all, if you have a trauma to that particular region, the impact may injure the nerves, and occasionally fragments of broken bone may also compress the sciatic nerve. See, this is also very important, and this will correlate when we talk about certain investigations. Spinal tumors might occur. Now, these tumors occur inside the spinal cord within the membranes, what we call as meninges, which covers the spinal cord. Or sometimes these tumors might also occur in the space between the spinal cord and the vertebrae. Okay, some malignant tumors might also occur. There might be secondary metastasis also at the level of sacroiliac joint by bone metastasis from a breast cancer. Okay, so or by endometrial carcinoma. So you just think in a malignant carcinoma wherein you have metastasis from the breast or from the endometrium coming to this level where it causes the spinal tumors and ultimately leads to sciatica. So the pathology is deep rooted in these cases. Then another similar condition is a sacroiliac joint dysfunction, which irritates the L5 nerve, which leads to leg pain, which can feel same as sciatica. Okay, so these are some of the common causes. Now coming to the risk factors, who are at the most risk of having sciatica? So in most known cases, pain begins with an injury after lifting a heavy object or after making a sudden movement. So we usually tell the patient suffering from sciatica that come whatever may, you should not give jerk to your lower back. You should not lift heavy objects suddenly. You should not thump or push anything with your hands suddenly in so that your back is hampered or there is jerky movement of your back. Okay, so coming to the what you can say risk factors, as I told you, 25 to 45 are the most prevalent, but the peak age is 45 to 64. So there are age, and this happens because in this age group there are age related changes in the spine which are common. Okay, so intervertebral disc also begin to deteriorate and grow thinner by the age of 30. So, and also in women 45, around 45, it is considered to be a menopausal age, and we all know that during menopause or after menopause there is sudden stoppage of estrogen and progesterone, and this immediately hampers the bone health of the female. Okay, so during the time of menopause, as the bones lose density, the cases or the chances or prevalence of sciatica occurring in female increases. Occupational factors, we all know, as I told you, obesity is also one of the major conditions. Because of obesity, the center of gravity shifts, and being overweight will also lead to certain other associated symptoms like osteoporosis, arthritis, RA, degenerative disorders. Okay, so these are the risk factors. Apart from this, risk factors and common causes, certain other miscellaneous causes might also lead to sciatica, such as spinal abscess, scar tissue, muscle strain, some infections, pelvic fractures, or other inherited disorders of the connective tissue. One new terminology that has come up nowadays, I would like to highlight it over here, which we call as cyclical or catamenial sciatica. Now, what is cyclical or catamenial sciatica? That is endometriosis. You all are aware that what is endometriosis. So in endometriosis, it can compress the sciatic nerve within the pelvis at the sciatic notch and in the gluteal region distal to the sciatic notch, or sometimes within the sheath of the sciatic nerve. So what happens is, patients present with pain in the hip and buttock, radiating in the leg and foot, onset is few days before menstruation and becomes progressively severe, and it subsides 2 to 3 days or 2 weeks after the cessation of menstruation. So it is all related to the endometrium, the endometrial tissue, the muscles, okay, and all related to the menstrual cycle. And that is why this terminology that is given as cyclical or catamenial sciatica. Now, when you say that you know about the cause, you know about the sign and symptoms, you should also know about certain examination or test that needs to be performed when you need to classify the patient as suffering from sciatica. Okay, so physical examination has to be done, and the first common test, that is the SLR test, that is the straight leg raise test, that needs to be done. What it is also known as the Lasig sign or the Lasig test. And what you do is, when performing the SLR, remember that the sciatic pain in the leg produced from 0 to 30 degrees indicates nerve root compression. If the pain is between 30 to 60 degrees approximately, it indicates sacroiliac disease. And if the pain is produced beyond 60 degrees, it always suggests that there are some lumbosacral conditions. Now, this is very, very important, because when you are performing this test, you should always see when the patient starts complaining of pain. And if you are able to note approximately that at what level the patient said or started suffering from pain, then you will always be able to make out the cause for it. Okay. And remember that it will always be negative in spinal stenosis. Okay. I'll not go into the details of this. You can easily see into the literature books of how to perform the SLR. Okay. Similarly, it needs to be done in a lying down position. There is another alternative that is known as the seated SLR. The technique is the same, but it is done in the seated position. Then you have the Bragard test, the hip flexion test, and the piriformis stress test. Commonly used is the SLR test. So that is why you should always perform that. Now, this test will help you to diagnose. But apart from this, there are certain imaging techniques such as the spinal X-ray or the CT scan and the MRI. And nowadays, you also have an electromyogram and a nerve velocity conduction test, which helps you in judging or diagnosing whether the patient has sciatica and what level the pathology has progressed. So if at all you see X-ray in an AP or a lateral view, it will help you, but X-rays cannot accurately diagnose if there are some soft tissue conditions such as degenerative disc disease or a typically herniated disc. So accurately, if you need the diagnosis or investigations, then you need to go for MRI. It will provide you a very well defined image of the soft tissue and the bone, and it will also detect the tears in the disc herniation or disc fragments, and it can also help you diagnose the spinal stenosis. But limited, again, MRI is limited to diagnosing structural pain conditions and often creates perfect circumstances for mixed diagnosed sciatica syndrome based on ischemic based sciatica. Okay, so you can go for a CAT scan, and in some cases we need CSF study also, because elevated CSF protein, they are the important indicators of functional status of the nerve root and a measure of the degree of seriousness of sciatica. Then you can also check for myelogram. Then scintigraphy is there, SPECT imaging is there. As I told you, nerve conduction studies are to be done, okay, to check for the velocity or the conduction of the impulses through the nerves. These studies are very important. Now, along with this was the part of investigations and all. Now, what you should suggest, or the auxiliary line of treatment, what you should tell the patient? You can ask the patient to use alternate hot and cold packs to reduce swelling. Then you should ask the patient to have good posture, perform regular exercises, careful lifting of heavy objects, avoid sitting or standing for extended periods. Then proper sleeping posture is a must. Stretching stretching, if you are sitting in a chair for a longer period of time, stretching is most important. Lying on the back and gently pulling the knees to the chest until a comfortable stretch is felt, you can do that. And then walking and swimming are the exercises which will help you to strengthen the lower back. Okay, along with that, definitely you would advise your patient to take help of physiotherapy. There are certain physiotherapic maneuvers. In my further slides, I'll show you some of the yoga postures also, which help in relieving the pain along with our medications. Okay, yes, these are the top 8 yoga poses. Definitely you should tell the patient to take advice of a certified yoga instructor. But you can tell them that these are some of the poses which you can practice, or if somebody himself or herself is knowing yoga, you can tell them to practice this 8 poses for yoga, which are helpful in relieving the complaints of sciatica. Okay, so these are again certain what you can say instructions that you can tell your patient to undergo. Yes. Now, what is the prognosis of sciatica? Now, here it is important to tell your patients this, because if they go to a surgeon, they will immediately put the patient under the knife. But you should tell the patient that most people, about 80 to 90%, fully recover from sciatica without surgery. And in most cases, the nerve is not permanently damaged. And individuals recover in 3-week to 3-month time frame. Correct? So this you should tell your patients. Coming to the homeopathic part, now I'll not go into much details of what homeopathy is, as we all know about what homeopathy is, but definitely totality of symptoms is important for us. Here I would specifically concentrate or tell you about 2 aphorisms, that is aphorism 147 and aphorism 252. Now, at the same time, when I talked about causes, I meant exciting and maintaining causes. So we must always refer to what causa occasionalis, as it is said by Dr. Hanneman. And yes, definitely aphorism 7 from the 6th edition is most important. But 147, why I'm telling you this over here, it is related to specific remedy. So in cases of sciatica, sometimes you need the help of specific remedy, which has been very beautifully described by our master in aphorism 147. And again, the minutest dose of the best selected remedy, when it does not effect an improvement, it is a sure sign that the cause that keeps the disease is still present. Okay, so the patient needs to change the mode of life, the situation which he or she is placed. So then and then only a permanent cure may occur, which is very specifically mentioned in aphorism 252. So the auxiliary line of treatment, the physiotherapy, it plays an important role, and that is being said in our aphorism 252. Okay. So I have tried to inculcate or take together the miasmatic approach for different types of pain, wherein neuralgic pains, you can either classify it under the category of psora or pseudopsora, shooting or tearing pains as psychotic, psoric or pseudopsoric neuralgic pains, which are relieved by quiet, rest and warmth, then syphilitic pains, which are worse at night, the psychotic pains, which are worse by rest. So these modalities will help you to classify the miasm of the patient. Okay, in SORA we have the numbness of extremities and tingling sensation. So all of this will be very helpful if you are very vigilant enough to catch the symptoms of the patient very diligently. Okay, so miasmatic cleavage, it goes as traumatic. If the cause is traumatic, then it is non-miasmatic or mechanical cause. If there is infective pathology, then post-herpetic neuralgia, it goes into psychotic preponderance, and tubercular pathology, you have a pseudosoric preponderance. If it is inflammatory pathology, then psychotic preponderance. And if the pathology is degenerative, like lumbar spondylosis, then syphilitic preponderance is there. Now, if you go to the repertory, there are many good repertories which directly suggest us medicine. Like in Kent's repertory, if you go to the rubric extremities, pain, lower limb, sciatica, directly it is given. And then in the sub rubric, there are right sciatica, remedies for right sciatica, left sciatica, then morning, night. In Phatak's repertory, the rubric sciatica is directly given. Dr. Phatak gives the sub rubric as ascending sciatica, cuffing aggravation sciatica, flexing leg amelioration sciatica, wherein one of the important remedies I would definitely like to mention it over here, Nephalium. Don't forget the role of Nephalium whenever you are treating a case of sciatica, specifically as a specific remedy. Okay, then Dr. Clark has also given the rubric sciatica. In synthesis repertory also, you will have the rubric. Then in synthesis repertory, you also have the rubric formication, wherein a single remedy of Nephalium is given. Then in complete repertory also, different rubrics and sub rubrics are given, wherein in front of them the medicines are mentioned. Okay, now going to the cases. Now cases, I would say, are not that important, because you and me or all our dear friend homeopaths will be having different types of patients, individual patients. So your approach might be different. The totality of symptoms, when you will take the help of repertory, you will take the help of organon, you will take the help of materia medica, and you will definitely get the similimum. But in cases of sciatica, the criteria for assessment is very important. So here is just a guideline which I am giving over here, that you can say after your treatment, you can categorize the criteria as marked improvement, moderate improvement, mild improvement, no improvement, or worse. Now, what is marked improvement? When the patient says that all the parameters are normal, relief at the general level, and the patient shows 70% or more improvement. Similarly, in moderate, it is 50% or more. In mild, there is less than 50% reduction. No improvement means no response after treatment is given for a sufficient period of time. And worse means aggravation of the subjective and the objective symptoms. Now, how will you classify these criteria? So there is a scale which is known as the DN4 scale, that is the Dollier Neuropathic Scale. Now, it is a screening tool for neuropathic pain. This consists of 10 items which is grouped in 4 questions. Okay. Out of this 10, the 7 items are related to the pain description, like burning, painful, cold, electric shock. What is the type of pain? We asked this. And to its associated abnormal sensations like tingling, pins, and needles. And the other 3 items are related to brief bedside neurological examination in the particular painful area. Okay. So whenever you classify these 10 items, 7 and 3 classified, you give scoring. And the scoring is 1 is given to each positive and 0 mark is given to each negative item. So the total score range is in 0 to 10. See, this is the chart. For interview of the patient, question 1, like, does the pain have one or more of the following characteristic? So you'll ask the patient of burning or painful cold or electric shock, and the patient will either answer in yes or no. Similarly, you have 4 questions, question 1, 2, 3, and 4. Okay. So for yes, single yes, there is 1 point. For no, there are 0 points. And alternately, you will take the score of the patient. So in regular follow-ups, if you're what you can say, what is your score? Depending upon your score, you can judge the criteria of your assessment, whether it is mild, moderate, or whatever classification you want to do. And along with this DN4 scale, you have a VAS scale. This is the most simple scale which is available, and it is a measurement instrument that tries to measure a characteristic that is believed to range across a continuum of values and cannot easily be directly measured. So you can just ask the patient of ranging the pain from 0 to 10, wherein 0 is the patient is not having any pain and 10 is the worst possible pain that a patient can suffer. Again, remember, dole is there. Okay, so a pain you can forget, a pain you cannot forget, and a pain that makes you forget everything else. So this is about the typical theory or the literature of what sciatica I needed to describe today. Hope I was clear. Then there are some cases. I'll not, 4 or 5 cases I have put on over here. I'll not go into the details of this, but definitely I'll show you about the repertorial chart that I had taken while considering the prescription of the medicines. So many medicines, and then my follow-ups. Yes, how I take my follow-ups. So I have taken about 7 follow-ups in this case. And this is how I told you about the criteria for assessment. So this is how I go on categorizing, wherein I definitely take the DN4 scale with my case paper. I have attached the case sheet of DN4 and the visual analog scale also. And then in every follow-up, I mark as how the patient is better by how many percentage. So here in this particular case, you can see the improvement has reached the last follow-up that I saw. The improvement is up to 60%. Then in a 46-year-old male, again, you can see he was a known case of mild lumbar spondylosis. He came with the report. And then I took the case, did the repertorization. The remedy I got was Nux vomica. I prescribed it. And then in 6 follow-ups, the improvement is almost 85%. With homeopathy, we are able to avoid surgery. This is what you can see. Another case of a 40 years old female. Okay. Again, the remedy that was prescribed after proper repertorization and taking help of Mater Medica was Kalicar. And then you can see after 6 follow-ups, the patient is totally relieved of her complaints. No complaints, and not only sciatica. Because we prescribe our similimum, all other general complaints that the patient had is improved. Similarly, a very young patient of 32 years of age was suffering from sciatica. So here also I prescribe the remedy Restox. So the patient is almost 50% better. Then again a housewife suffering from sciatica. Again the remedy Kalicar, it was given, and the patient is almost 60% better. And yes, there were cases in which in between the general complaints relapsed. So I had to repeat my similimum again. And then the patients were much better. So I hope this was beneficial. I'll stop sharing the slide.
Thank you, sir. Thank you very much.
I hope, sir, this was beneficial. I had to constrain it within 1 hour. Whatever literature material I could show, I was a little bit fast, I think so. But yes, I need to go through it because literature for sciatica is way much nowadays. Research has been done on it. So it was difficult for me, but I hope I was able to explain it in a better way.
Thank you very much, sir. It was a very nice presentation because so simple, but you are described it in a very simple language and simple. We can all the words you use, but we can absorb it. So now, thank you very much, sir. Now this is the time for. I am very much impressed because of the scale. DN4 scale. This is the first time I am hearing that. So this type of so many technical terms are you used. Sir, thank you very much, sir. Now this is the time for somebody want to ask. Please raise your hands,
yes,
and I will
please,
allow.
Please. Yes, anyone, please feel free to ask. If any questions, I would be more than happy to answer them.
Ram Pravesh, sir. Unmute, sir. And ask.
Thank you, everyone. Thank you, Dr. GAURAV BHATT. Very nice presentation, excellent session.
Thank you very much, sir.
This deals sciatica or every clinic, sciatica patient is always, you are
Yes, yes,
dealing
very common.
miasmatic cause, background
Very
of
common.
background of Sora, very nice.
Yes, sir.
Sora psychotic, sciatica, miasmatic treatment, very easily treatment and curative way of treatment.
Yes, sir.
Psychotic and holistic, you are very kinds of presentation, holistic presentation and beautiful presentation or deals medicine and according to repertory, very nice. Thank you.
Thank you,
Thank
sir.
you.
Thank you very much,
Thank
sir.
you, sir. Thank you, sir.
So,
This is the first time I am hearing that Nexomi can be prescribed for sciatica.
That is the beauty of homeopathy, sir.
Now, Sridhar Group, sir, our veteran.
miasmatic role of sciatica, medornum is the very curative way of treatment. Medornum, medornum very curative way of treatment. So sciatica, miasmatic role. Thank you. Thank you.
Thank you, sir. Thank you, sir.
Group, sir, please unmute, sir. Group, sir. He raised his hand because of there may be
Yeah, sir has
network
raised
problem.
Dr. T.N. Shiddur.
Yes. Group, sir. Unmute, sir. Unmute.
Sir, you need to unmute, sir.
Okay.
Okay. Now ask.
Okay. Sir, it is Gaurav, but it was a very good section. Excellent.
Thank you, sir.
But I am not so far, even a single case, I am not failed in the sciatic problem.
Yes, sir.
Okay. It is a very good area for the homeopath.
Yes, sir.
So they are suffering. The suffering is when once you may suffer, then you will come to know the difficulties, unbearable pain.
Unbearable. Yes, sir.
So that it is a so many cases, so-called incurable sciatic cases, a homeopath can cure. So it was a very good scientific way of approach. You are not taught. You made all the others to how to catch the fish, not to be simply feeding to the fish directly. So I congratulate you. Come again with
Thank you,
such
sir.
a wonderful that section. Thank you very much. Wish you all the best.
Thank you. Thanks a lot, sir.
Now, please say word of thanks also, sir. Group, sir.
Yes, sir. You said about from the everything A to Z, but it is very efficient presentation, and come again with such a wonderful presentation. Thank you very much. Come, in behalf of IFPH and to the doctors and to the all others who are present in this, I am giving my sincere thanks to you in behalf of all the doctors, students, and well-wishers. That all that I give from my sincere thanks. Thank you. Come again. Bye. Good night.
Thank you, sir. Thank you for giving me the opportunity, sir. Thank you for giving me the platform. Thank you, sir.
Yes.
Now, here we are concluding our English session. Tomorrow this time, 8 o'clock, there will be our English session. And now we are passing to our our local language Malayalam session. So thank you very much. Again and again, I say thanks to you. We are very much grateful to you. Now we are passing to our